Hello, everyone. Very humbled to be here today. I stand up here as a recognized data nerd. I'm going to share with you, hopefully, some interesting information about the state of Iowa, but really, as Dr. Hunter did a wonderful job introducing, we're all here because we care about changing the trajectory of some of the data that we see. Right? Providing opportunities for women, providing opportunities to connect them with the services that they need, making sure that whether you live in very rural Iowa or central downtown Des Moines, that you have access to what you need. So thank you, Janet, for introducing me. Thank you, Megan, and all of the Healthy Birthday team for inviting us to be here today to share with you a few little McNuggets of data about what's been happening in the state of Iowa over the last few years. As Dr. Hunter introduced, 2018 was kind of a pivotal point. Lots of hospital closures happening in 2018. What I'm gonna share with you today are some data from before 2018, and then some recent updates about what are we seeing across the state since 2018. So let me just give you a couple minutes of background about our team and what we do at I2D2. We are a data shop. We are a data shop that works in partnership with our state of Iowa colleagues, wonderful folks like Janet and others at the Department of Health and Human Services and Education, to try to bring data into conversation to use for decision making. And what I mean by data in this case is all the administrative data that sits in computer systems. All of the records that folks collect on folks that we're serving, and we bring that all together from across systems. So we can talk about things like what happens when children and families leave home visiting and they go into other programs like preschool or kindergarten, what happens to them? Where are we serving families? Where are we missing serving families? And that's what our data system can do. There's a video on our website if you're interested in learning a little bit more about what we do, but essentially we bring data together, but we bring people together to talk about those data and try to help make decisions.
The vision of early childhood Iowa is that all children will have the foundational early experiences they need to be healthy and successful. We know this requires considerable collaboration and coordination among our health, education, and social service systems to ensure all families have access to what they need when they need it. Iowa's Integrated Data System for Decision-Making, I2D2, is here to help by providing data insights to guide strategic planning. We believe that by integrating people and data from across service systems, we can address Iowa's most pressing problems and improve well-being for Iowa children and families. Here's how I2D2 works. Throughout the life course, individuals generate data in the form of records and documentation. When a child is born, health and demographic information about them and their family is recorded. If that family is enrolled in home visiting services, records are collected and stored for program monitoring and evaluation. When a child is referred for a developmental evaluation or enrolls in public school, additional records are created. These records, called administrative data, are collected by individual systems under authority of different public agencies. This creates data silos. These data silos can't answer pressing questions to inform decision-making. How many children are served by multiple systems? What happens when children transition between one system and another? Siloed data are a problem for collaborative decision-making that requires systems to work together to best serve families comprehensively. These are the problems that I2D2 solves through a process of secure data record linkage. I2D2 brings together data from these siloed systems, generates anonymized files for analysis to explore patterns, predictors, and relationships, and uses analytic findings in cross-agency discussions about Iowa's pressing problems. This is how cycles of inquiry through I2D2 advance strategic solutions. Are Iowa's most vulnerable children accessing high-quality preschool experiences? Do workforce investments support parents with young children to break intergenerational cycles of poverty? Do early home visiting services provide families with the supports they need to advance development and prevent maltreatment? Developing high-quality data, dialogue, decision-making cycles to advance child and family well-being is the business of I2D2. We believe an early childhood system that is effectively and efficiently coordinated using integrated data will improve the lives of Iowa families. Now that is a strategy worth investing in.
So we have a pretty large team that's helping bring this together. These are some of the folks here on our team. I have some fellow team members here if you'd like to learn more from them at some of our breaks today. But as Janet introduced, we're here today to talk about one particular set of analyses that we've been working on, trying to understand from a statewide perspective what's happening with families as a result of these birthing hospital closures, and how can we use that information to drive strategic programming or improve the programs that we already have. So I'm going to share with you two different sets of data. Phase 1 was before 2018. Phase 2 was after. So for phase 1, we did some administrative data collection. We did some interviews. Again, focusing on folks that come into contact with women that are living in areas where hospital closures have happened. We spoke with home visitors and asked them a little bit about, what are you experiencing? What are families telling you? What are moms telling you that they need? And this is a data study from 1999 through 2017. So we looked at all of the closures that Dr. Hunter shared with you that happened before then, before 2018. In general, we looked both at county level findings and then individual records to see what was happening with women. On average, those counties where we had a unit closure saw higher rates of inadequate prenatal care and later month of initiation of prenatal care. We looked at several different outcomes. We looked at not only prenatal care, but we looked at preterm birth. We looked at birth outcomes like low birth weight. We also looked at characteristics of moms, because what we were interested in was not only the statewide picture of all women, but are there particular groups of women that are maybe faring better or less well in the context of a birthing hospital closure. So those subgroup analyses were really trying to find, do we have groups of women that we could maybe help support recruiting into home visiting programs or recruiting into the other programs, a lot of them that you're going to hear about later on today. We want to identify who may benefit most from some of those additional services. With this first round of analyses, I mean, what we basically found, if you're trying to look statewide, it's a really big lens, right? When we look statewide, we didn't find the large direct effects on birth outcomes, but we did see outcomes, indirect outcomes happening through their effects on prenatal care. Let me show you what that looks like. So essentially, in cases where we had hospital closures, what we would find is that women overall had less adequate prenatal care. That means they started later and they had fewer visits overall. In general, when women have less access to prenatal care, they have poor outcomes, right? So, and what we saw with this was some interesting findings with subgroups, and this is where it gets important to think about how are we recruiting women into some of our programs that we do have in some of these counties. What we found were some positive effects and some challenging effects that helped us think about who would we recommend for additional programming. In this first round of analyses, in the year after a closure, what we found actually was that single moms were attending more prenatal visits. Okay, so we were doing a better job at getting single moms in around a closure in those areas. Similarly, we found that women who were enrolled in WIC and Medicaid at the time of birth, so women that were already connected with some services, they started their prenatal care earlier, they had more visits overall, and they were less likely to receive inadequate prenatal care. Okay, so these were some positive spots, areas in the state, particular groups of women where we were seeing them being connected in the context of those closures. One area where we found a challenge were moms with lower education. Now, in this case, what we're talking about is moms that do not have their high school diploma. So they're over 20 years old, but did not receive 12 years of schooling. For moms with lower education, what we found around a closure, again, this is before 2018, was that they attended fewer prenatal visits and they started prenatal care later. Okay, so this was a particular group of women that we were interested in, and in a lot of our dialogues with Janet and some of the McVie teams, we're trying to think about, well, who are these women? Are they living in certain geographic areas of the state? Are there more concentrations in certain places? And particularly, are these women connected with WIC and Medicaid services? Because if that's a protective factor, what would that look like? So we did a little bit more work looking into moms with a low education to see if they were also connected with some of these other services that were showing a protective factor. So overall, about 3,600 children in-home visiting are born to moms without a high school education every year. So we're talking about a relatively large population that we could potentially influence. What these findings were suggesting that is if those women were connected with WIC and Medicaid, we found a buffering effect. Okay, so those services were helping connect women with the prenatal care they need because in the context of a closure, they were not seeing the same outcomes as other women who were not connected with those services. So that was a positive outcome. Now I want to show you a little bit from our qualitative results as well. So as I said, we did some interviews with home visitors across the state to try to understand their experiences with women in the context of closures. And these interviews were done around 2019. So this was right about that same time frame, reflecting back on the last couple years of closures. Across these interviews, we found 4 relatively larger themes around transportation. So women sharing challenges with transportation when a closure happens, how far they have to go to get their prenatal care or to have their child delivered. A second theme, having impacts on prenatal care. So home visitors shared challenges with attendance and access to that care. The third theme was insurance. So finding places where women could go to deliver, given the insurance that they had or given their Medicaid status, who had available opportunities for them to get services. And the fourth theme was around relationships. This one was really key when we think about the relationships we develop in our communities. When women were having to go different places, they would meet many different providers in their journey of pregnancy and delivery. And that made it harder for them to develop relationships. These are just a couple quotes. I'm not going to read them for you. I know our slides are going to be shared if you want to read more. There's also a lot more information in our report from these interviews if you're interested in reading more of those. But this just kind of gives you a little bit of flavor of each of those themes around transportation, around challenges with getting access to care, and this bottom right one here about those relationships. Having to build and rebuild those relationships when there wasn't a consistent place to go. Now I want to transition to phase 2. So phase 2 now, we updated these analyses post-2018. So as Dr. Hunter said, there were a lot of birthing hospital closures in 2018. We wanted to update these data and see, well, what has happened most recently, and particularly given a lot of the interventions that have been going on and being rolled out across the state as well. Which makes it a little bit trickier from a data perspective to try to look at statewide trends when there's a lot of really intense and good work happening in certain pockets of the state. So I want to show you what we did here with this update. Can I click here? Oh, there it goes, okay. So this update includes 10 additional hospital closures. So we updated it with all the births across between 2018 and 2020, and we incorporated these closures in the study. We wanted to see, are we seeing the same impacts? Are we seeing the same outcomes? Are we seeing the same outcomes for those subgroups that we showed you in the prior analysis? As a little bit of a context for this, I wanted to show you some trends in some birth outcomes between these 2 time periods. So the graph shows you on the x-axis, this goes from 2010 through 2020, and these are trends in Medicaid receipt, which is the black line, inadequate prenatal care is the purple line. Those 2, relatively consistent over that time frame. We've seen a decline in WIC enrollment, so that's the gray line, from 36% down to about 29% in that time frame. We've seen increase in inductions. So induced deliveries in that same time frame. Tobacco use has declined over that time, and teenage parenthood has declined. So this is just a context I wanted to share with you as we look at the impacts of the birthing hospital closures in those later times, because some of these trends are important. If we're trying to look at, for example, what's the buffering impact of WIC or Medicaid, we want to be able to see, well, is this generally happening across the state or just in those areas where we're seeing closures? So, summary, phase 2. I'm going to show you a couple of graphics, but I want to give you the summary of what you're about to see. In phase 2, we did find an overall impact on preterm birth. So this was something we didn't find during phase 1. Remember I showed you those, we saw more indirect impacts of those closures. So closures were impacting prenatal care, and then prenatal care was impacting outcomes. What we're finding in more recent years is, and I think Dr. Hunter alluded to this a little bit too, is we're seeing more direct impacts in some of those closure areas where we are seeing more preterm births. On the positive side, so this is my thumbs up side, we're seeing more buffering impacts for moms with a low education. So whatever you all are doing to connect with this particular group of moms, this is showing a good impact for moms in the context of closures. They're starting care earlier if there's a closure. They're attending more visits if there's a closure, and their odds of prenatal care are no different than they would have been. Okay, so these are changes between 2017 and now these most recent analyses. Now, one of the other things that we found, though, which we're still puzzling about, and I think this is part of what I'm looking forward to hearing a lot more about later on in our day, is we're not seeing overall that buffering impact of Medicaid and WIC. Now, I have a sense that it's because there's a lot of interventions happening within pockets of areas of our state, and we need to know more about what's working, so that it's not something that's universal, it's something that's happening as counties are figuring out ways to get women the care that they need. So we need to learn more a little bit about that. I'm going to show you a couple graphics now just to illustrate these points. This graph here, the left side, phase 1, that's the pre-2018 data, and phase 2 on the right, that's the after 2018 data. And what you're seeing, the left bar is the year before a closure, the middle bar is the year after a closure, and the gray bar is your comparison. So all other births at that point in time. The main point of this graphic is just showing you that the red bars are higher, okay, in phase 2. So what that's showing us is that we have higher rates of preterm birth in the most recent years of closures. Another one I want to show you is around inadequate prenatal care and maternal education. So let me orient you to the slide here for a minute. We have 3 sets of bars. On the left side are cases where there's been no closure. The middle bar is a year before, and the third set of bars is the year after. Now what I'm comparing here is the reds and the blues. All the reds are moms with a low education. So moms that do not have that high school degree. All the blues are moms that have a high school degree or higher. The left red bar is phase 1. The right red bar is phase 2. So before 2018, we saw this closure effect, okay, where moms with a lower education were actually having poorer outcomes. But what we see now is that's gone. So if you look at the green line, those bright red bars, they're about the same. There's no difference between having no closure, a year before a closure, or a year after a closure. So that's a good thing. What we're seeing is that moms with a low education are getting more access to the services than they were before 2018. Now I'm going to show you what the picture looks like for WIC. So in phase 1, if you look at these red bars, see how the light red bars are above the line? So in 1 year before and 1 year after, they're above the line. So that's what we're showing as a buffering effect. So those moms with a low education, when they were participating in WIC, they actually had experienced more visits. They were attending more visits. Now, phase 2, we're not seeing that impact. Overall, Now, I want to stress this. Overall, I mean across all of the counties when we're comparing those that have seen closures and those that have happened. So I think this is why we're in this space right now. We need to learn more about what's happening within the counties because it's not as clean of a picture as it was as well. So we need to do some more work and see what this looks like. So in summary, between phase 1 and phase 2, we're seeing some main effects now on preterm births, but we're seeing moms with low education are doing better in recent years, but we're also not quite sure what's happening with our WIC and Medicaid program, buffering effect that we had. We have a feeling there's more buffering effects that are happening out there that are not accounted for in these data, but we need to learn a little bit more. So here's what we're gonna be doing next to try to continue this dialogue, and this is why we're here today too, is to learn from you all about what you are doing in these counties. Here's a picture of some of the birthing unit closures between 2018 and 2022. Here's all the places where we've seen units close, the red. What we're gonna be doing now is trying to understand, well, what's happening in some of these counties? What are some counties doing similarly, differently than others? How can we understand that in the context of maternal outcomes so we can promote more promising practices, find out what's working, expand what's working to other places. One of the interesting things that we found just taking a look at where women are giving birth. So comparing this slide, so the red here is where all the units have closed in those recent years. Now look at where women are going to give birth. So the stars, that's where the birthing unit closure happened. So this picture is just to show you they're not necessarily going right to the next adjacent county to give birth, okay? Some are traveling large distances. They're really kind of spread all over. So, and what does that mean for us? We need to understand that a little bit more. One last thing I want to share with you, and this is going to be our next steps that we're going to be doing in partnership with you all, is to understand how can we look at counties where things are working, counties where women are having more challenges, and we're doing something statistically called matched pairs. So what that means is we're taking a look at counties that have maybe the same characteristics of their population, but very different outcomes. Or on the opposite side, maybe there's counties where we see very similar outcomes, but they're very different characteristics of families. So that's what this is showing you here. They're called risk clusters. So if you look, the red box with Osceola, Chickasaw, and Washington, these are counties where they have very similar risk patterns, so very similar characteristics of who lives there and women that are giving birth there, but they have different outcomes. So they're on a different line on the outcomes. There's other counties, if you go across this way, that show very similar outcomes. So birth rates, gestational age, prenatal care, they're showing very similar outcomes, but they show very different risk characteristics. And we can study these to try to understand more about who are we reaching, who are we not reaching, how can we reach more of the women and families that may benefit from services. So this is something that will be coming up next, but I just wanted to give you a sense of where we're going, and we're going to be looking to find out more about what's happening in some of these counties as these closures have happened. So thank you very much for your time today.
Now we get a chance to ask questions. And I always say really good data should cause you to have questions. You want to know more. It should get your curiosity going. So does anybody, we have microphones circulating. Okay, yes? So if you have a question, you want to raise your hand? Yeah, okay, we got a question already. Thanks.
Hi. In Dr. Hunter's talk, he said that hospital closures led to more women having home birth, and in your discussion, you said that hospital closures had an effect of lower educated moms having better outcomes. Are those two things related?
Yeah, that's a good question. So let me rephrase. I think what I'm saying is low-income moms with a low education are having better outcomes than they did in 2017. but not necessarily better than other women. Does that make sense?
Would those two things be related?
That's a good question. That's something that,
Like, are those women that are having better outcomes than they did because of the hospital closures going to home birth, where they're getting really good education?
yeah,
We don't know that.
That
That's-
might be some great data collection there.
that's a really good question, yes. Our data wouldn't be able to tell us that right now.
That is a great example of what I was talking about, of that data sparks your curiosity to say, ooh, I wonder if there's a correlation here. It's not information that we have today, but it helps give us a good direction for where we could go. Other questions? Oh, we've got a couple people circulating with mics. Okay, we've got somebody online. While that person online, while we're getting that question, I had a question. I want to ask Dr. Rouse how low education was defined, because I think that's also a critical piece of information.
Yeah, good question. So for this particular subgroup, what we looked at were moms that were at least 20 years old. Okay, so age-wise, they would have been old enough to graduate high school, but they did not have at least 12 years of education. Okay, so less than 12 years of education, but at least 20 years old. So this is not teen moms. So that's an important distinction to make here. We're not talking about teen moms. That was a different subgroup that we looked at. These are moms over 20 who have not completed high school.
Okay. We've got somebody online, and then we've got a question down here.
Yes, the online question is, do you all know the average time spent traveling for those in counties with a closure?
I think that was in Dr. Hunter's report. Yeah. I think we do know that information, but that was in Dr. Hunter's work, and I know he's going to have a chance for question and answers later, so we're going to hold that question for when we get a chance to have Dr. Hunter answer questions.
I wanted to piggyback of hers, but that data point, it makes me nervous because there can be a direct correlation with low education and lack of desire for prenatal or supported birth experience. And so when you present this data point, are we also, the first thing that came to mind is resources, right? So proximity. And because then usually if you have low education, you probably are lower earning, which prohibits you from transportation and ability to receive care versus interest in receiving care. And I feel like in this space, that is a very important distinction to make, that although you are low income or low education, often that's an opportunity and not a choice. So just concerning to me.
Yeah, no, that's a really good point, yes. So we don't have the information about transportation or access in these particular data, but you're exactly right. What we can say is that these characteristics are related to these things, but we don't exactly know why. You're right. We need more information about that.
Yeah, and
it's a
then
really
home
good
birth,
point.
we do know it is safe, and when we have midwifery care and doula support, that can be an immediate solve, which I know when we have Health and Human Services or government support and funding, I feel like you are the perfect person to provide that data, so we have those facts to feel confident in funding those effective solutions and affordable.
Very good point.
Yeah. That was a great question, and it's been one that's been burning in my mind, because I want to know where those moms with the lower education that are where they're at, because are we reaching them at home visiting, which is one of my concerns, and how are we reaching them in not just home visiting, but other programming? Again, and why were they not on Medicaid and WIC? Because they would have qualified. So what's the barrier for that as well? So I mean, there's it was one of those data points that was like, I got about 20 questions that goes along with that of I want to know more, and I want to figure out how we can better connect our services to that group of moms as well. We have other questions? Okay, I see a hand up over here. Oh, we got a hand. Oh, we got somebody over here.
I was wondering about the dates on your data. am I correct that it's 2018 or 2017 that you began this study?
Good question. So we started the study, I want to say in 2019, but the data that we presented, so the phase 1 data that we showed, that was all of the births and closures from 1999 through 2018. And then the phase 2 closures that we showed you were 2018 through 20. So this, these data reflect 20 years of closures just separated into 2 chunks.
And how about the low education in the mothers? What about that data? When did that start? And what is your base at your lowest point?
Yeah, good question. So for all of those births, we had information about mom's education level, mom's marital status, all of the different variables that we looked at. So those data were included across the board for 1999 through the 2020 data that we showed you. Good question.
Okay, there's a question here, but there's somebody over here.
Is there a plan to include first responders in like the data collection and the training, since they probably are seeing more?
You wanna take that?
Yeah, that's a
Wait,
really,
Dr. Rouse, could you repeat the question for the people online?
Yes.
Thank you.
So the question was, is there a plan to include first responders in data collection moving forward? So we have, and training, so that we understand more what they're doing and what they're seeing on the ground. Yeah, that's a really good question. Would love to include that moving forward. We will take those notes. Yes, thank you.
Okay, question over here. Oh, online.
The question is, do patients have to give permission to give their data to I2D2, or do they know their data is being used? How many people are we looking at approximately when looking at these data sets?
Okay, good question.
Yeah, very good question. So these are the statewide vital records, so it's everyone in the state of Iowa. The way these data are handled, there's legal agreements in place to access and use them for analytics on behalf of the state. They're all anonymized files that are used for analytics. So it is the statewide population of all births in Iowa.
With that data that was presented with the WIC and Medicaid services and home visiting services, I was curious if there was any data, especially post all the other closures, on the amount of, or if there was an increase in referrals from delivering hospitals for those services, such as WIC and the home visiting. Did we see an increase in referrals?
Very good. Yeah, we don't have referral data in the vital records that we were looking at for this. That would be a really good data point to be able to look at, though.
Without data, I can tell you just casual observation, there, especially with our rural hospitals that are still delivering births, we've made a better connection. And where there's been hospital or birthing center closures at hospitals, we've had to work, and from the home visiting perspective, we've had to work more closely because we're in this together. We want good health, we want good outcomes, and we will share, this is what we're seeing, the quote about the mom camping out in the parking lot. And I thought, I've heard those stories. And hospitals care about that as well. I mean, they're in the business of healthcare, so that's important to them. So there has been, I would say, a better connection. I've been working in home visiting for 34 years, and I would say in the last 8 to 10 years, all of a sudden there's a better connection between home visiting and hospitals and medical professionals.
Oh, there's a question down here.
All of the 3,600 babies that you had reported in the low education and low birth rate, low status of their birth, how many of those do you feel were Amish and Mennonite communities that were in that large or that low education populace?
Can you repeat the question into the mic, Dr. Rouse?
Sure. The question was, how many of the women with low education were from our Amish community in Iowa. That's a really good question. We have looked at that. I don't know the numbers offhand. We know that is definitely part of our population in Iowa. And I know I probably have colleagues that could give me a better answer than that, but we know that is definitely part of the population. Thank you for the question.
Again, speaking as the non-data person, I can tell you when I looked at the data, it does not account for the entire story, though. I mean, I know where the pockets are of higher Amish and Mennonite population that may choose not to receive prenatal care in a hospital, and it does not account for all of that. It actually made me think of, are these immigrant families that are working in a factory that cannot get away during the day for prenatal care? Was that a possibility that also did not have a high school education? I don't know the answer to that, but that was a direction that I went with. Who are these families? Where are they? How can we reach them? And again, it's my burning question as well.
Are we doing anything to reach into those populaces to provide education, even just along the lines of prenatal birth education?
I can only speak at that from the home visiting perspective. About 37% of the families we serve in home visiting would be from that population. And so it's the push that we make all the time. We have a limited number of families that we can serve. And what can sometimes happen is more moderate risk families that are more sophisticated and understand how to access these services can take up a slot. And so it is that constant push of these services are for high-risk families. We need to make sure we treat them like little golden tickets, that we are giving them to the families where we can make the most difference, because data will also show that when we do that, when we serve the higher-risk families, we get better outcomes. It's a better investment of your money.
Can individual entities make requests for data or pose questions to I2D2 to get some answers? Some of us really want answers. We have lots of questions.
That's a really good question. So our longer conversation than we have today, the short answer is I2D2 works with a pretty strict governance process that includes leaders from all of the entities that contribute data to the system. So yes, there are ways to have conversations with the leaders that can decide what's done with the data. I don't have ultimate authority to say, here's what we're doing with the data. It's done with stewardship committee of appointed leaders from each of the agencies. But the short answer is yes, we can have conversations about what that would look like, and there's a process in place to do that.
Hi, yes, I have a question. One of my questions is, how many of the women in the counties that have been closing their hospitals, it looks like it's around the perimeter of Iowa, how many of those women do you think go, say, to Omaha or to Illinois or South Dakota? I feel like I've noticed a lot of my members that are still with Iowa managed care organizations deliver in those other facilities. I think that would be kind of an interesting question.
Yes, absolutely. We've tried to look at that a little bit. You know, our team's lens are administrative data. So where those administrative data have information about women that have gone out of state, we can look at that. It's not always clear or within the bounds of the legal agreements we currently have. So that was a long answer, but yes, very good question. We're trying to figure out more about what that looks like and whether we can do an administrative data look, or we need to think about something else that goes across some of those borders to understand more about what's happening. We've definitely been talking about that.
Okay, and one other thing is a solution to some of the problems with members not maybe getting into WIC or Medicaid. It seems like a lot of my members will say the first time they found out they were pregnant was that they were so sick to their stomach that they went to an ER. And in the emergency room, they were determined to be pregnant. Maybe they would do a little ultrasound, maybe not. If the ERs could have some information and say, look, if you join up with Medicaid, all three of our MCOs that are in Iowa, I'm pretty sure, at least I know Iowa Total Care, plug, does have access to care. We will provide 30 cents per mile to and from if they drive, or another family drives, they can also get that money. Or we will go to pick them up and take them to and from WIC, Medicaid, dental, mental health problems, physical therapy. So there are many of those things, but they don't know this. So if we could plug that in to where they are first being noted to be pregnant, like the emergency rooms, I think that would be a good place to start.
Totally agree. I mean, I think there's a lot of work that we could be doing in emergency care. My stepson who is a registered nurse, was so excited to report to me about his first birth that he helped with. You know, my mind was in a different place. Instead of being all excited for him, it was like, you have no business helping with a birth. You know, first of all, when it's your kid, you just don't see them doing these adult things. But it was like, you had how much training in your nursing rotations in in OB, and you've never done this before, and you work in the ER. So again, I just see there's need for more support in our emergency room, and someone mentioned earlier, emergency responders. These are people that we need to be getting more information to about lots of different things that have to do with maternal care. I also wanted your first question about people going outside of Iowa. We do have people also coming inside to Iowa. I know you're going to hear later on from Dr. Wells, who delivers babies at the Wayne County Hospital down on that southern border with Missouri. And I know they have people coming from Missouri, central Missouri, which also does not have any birthing centers. They come into Iowa to give birth. And I think we could look at that both ways, but then it becomes somewhat of an issue for some of the supports we want to have in place of we can't use Iowa dollars for those Missouri families, and it's probably the same thing for families from Iowa going outside. There are certain supports that they would not be eligible for and receive. So that's a whole nother question for a whole other day, I think. But it's how do we make our borders a little more fluid for some of these services, because we have people coming in and we have people going out as well. Other questions?
Yes.
Two more? Okay.
I was wondering about when you collect your data, is there a place where you're collecting information about fear in the system where it hasn't worked for that particular woman, or even family history? I know we collect history about a diagnosis, but about outcomes and fear of just the system performing well for that particular person or that group of people for that matter.
That's a good question. So the information that we shared today was really limited to what's captured on a birth record. So just that one event right at the time of birth. I would imagine there's a lot better records at the hospital level around that family history and those kinds of things. So, but that's beyond my ability to speak to. But I think that was a really good question about data that would be relevant for this discussion.
Many people don't go to a particular hospital because they've had maybe a bad incident, or the family has had something happen, or there's, for a whole group of people, a generational problem with a particular system not functioning for them.
Thank you. Okay. Well, thank you all for your time. Wonderful questions. We'll be writing down a lot of other information for the rest of the day. So thank you.